My name is Sze Ting Lee. I'm a nuclear medicine physician at Austin Health in Melbourne and the current president of the Australasian Association of Nuclear Medicine Specialists, or AANMS. The AANMS is the peak body representing medical practitioners working in the field of nuclear medicine diagnosis and therapy, ensuring that the highest standards of nuclear medicine is practiced in Australia. Nuclear medicine uses unsealed radioactivity or radiation to treat and diagnose diseases, including the 5 highest causes of death in Australia, namely heart disease, dementia, stroke, cancer, and lung disease. And there are now also targeted radionuclide or nuclear medicine treatments for many cancers. Our main priorities as AANMS is to provide equitable access to life-saving diagnostics and therapeutics with unsealed radiation sources, which we have the expertise to perform for over 80 years, which is more commonly known as theranostics these days. To do this, we need to get nuclear medicine Medicare items re-indexed, which has not been indexed for 25 years and remains the only medical imaging modality which remains unindexed. Therefore, the re-indexation of nuclear medicine items on the MBS offers an opportunity for government to fulfill this commitment and support the best possible health outcomes for Australians. The federal government has indicated its commitment to strengthen Medicare and enable concrete results for patients, in particular through supporting access to care, which is modern, inclusive, and harnesses this critical medical technology to address the changing needs of the Australian community. Nuclear medicine is a vital component of the Australian healthcare system, and there are over 800,000 nuclear medicine services delivered in Australia every year. On average, every Australian is likely to need at least 2 nuclear medicine services during their lifetime for the diagnosis and treatment of a wide range of conditions. Nuclear medicine can save healthcare resources by reducing the duplication of less accurate diagnostic tests, as well as the earlier diagnosis of diseases with better prognosis. For example, targeted treatments for melanoma is available these days, and to ensure that patients are deriving benefits from the life-saving immunotherapies and they are not receiving these expensive therapies in vain, these responses can be reliably assessed with a nuclear medicine scan called a PET scan, or positron emission tomography scan. There is increasing research and development in this space with proven benefits of nuclear medicine scans over conventional scans of CT and bone scans, as was shown in the PRO-PSMA study, which we have talked about on this very news channel last year. Data from the ABS indicates that migration out of Australia's capital cities is continuing to rise, with figures from 2021 setting a new net loss record for capital cities. This came as 66,000 Australians made the move to regional and rural areas, which is the area of greatest impact given the constriction of nuclear medicine services in these areas due to the lack of indexation. The Cancer Council argues that there is a renewed urgency to tackle these inequalities, given that so many Australians are leaving the cities due to the repercussions of COVID-19. There was a report by the Victorian Cancer Agency at the end of last year, which estimated that there was 4.3% fewer cases detected in 2021 that would be expected based on historical trends, and this was on the back of 7% less diagnoses in 2020 during the height of the pandemic, where patients were less likely to see doctors for health checkup or for even a breast lump. This means that we have a lot of Victorians and presumably Australians around the country with undiagnosed cancer, which only worsens their prognosis, as we know that earlier diagnosis and management of cancers improve survival. And I'm seeing that in my clinical practice with more advanced cancer presentations, for example, breast cancer and thyroid cancer. Since 2017, there has been an annual decline in the number of nuclear medicine trainees in the profession. In 2021 and 2022, there were only 25 trainees across 44 accredited positions each year. Our members have indicated that this is due to a combination of the inadequate funding and a lack of interest in nuclear medicine training due to the perception that other specialties are better funded, remunerated, and supported by the government. To date, nuclear medicine remains the only medical imaging service that has not been indexed since the former coalition government initially froze indexation of all Medicare rebates in 1998. In the last few decades, the effective cost of nuclear medicine for service providers has grown rapidly and became unsustainable, resulting in higher out-of-pocket costs to patients. Since the reintroduction of the rebate freeze on nuclear medicine items, inflation has also risen over 63%, and the cost of delivering nuclear medicine services has grown significantly. This is partly due to the steep increase in the cost of radioactive isotopes, partly due to the global supply chain issues, and this is on top of the rise of the cost of basic radio tracers, for which the price was protected by ANSTO over the pandemic, but this has increased now between 2 to 5% in October 2022, with a further price revision again in 2023. A failure to address these issues will result in further constriction of nuclear medicine accessibility and availability throughout metropolitan and rural Australia, and reduce the capacity of our health system to successfully treat patients with serious health conditions, resulting in poorer health outcomes and increased costs to the economy. The AANMS recommends that the government commit in May 2023 budget to reindex all nuclear medicine items on Medicare for a relatively paltry sum of approximately $5 million annually for a 1.6% indexation subsequently. Doing so would support the overarching goal of the federal government to strengthen Medicare and to ensure life-changing healthcare for all. The AANMS has broken down the impact of the lack of indexation into three main points. Firstly, increased out-of-pocket costs for patients, reduced access to nuclear medicine services for rural and remote services, and reduced availability of nuclear medicine services across Australia. On the first point, nuclear medicine practitioners may continue to provide nuclear medicine services, but are forced to shift more of the cost provision onto patients to maintain their economic viability. This will result in nuclear medicine services becoming increasingly cost prohibitive to patients, especially in the rural and remote setting. The pressure to bulk bill is very high, and many would rather cease providing a test that is marginally or non-profitable rather than risk patient non-attendance, delayed payments, and the cost of administrating the Medicare processes. In situations where Medicare diagnostics testing is superior to alternative testing, but patients are unable to access the nuclear medicine test due to increasing out-of-pocket costs, there will be increased risk of adverse health outcomes and additional downstream costs on the health system. Secondly, the impact of reduced provision of nuclear medicine service and increased costs resulting from a lack of indexation is being felt disproportionately within the rural and remote areas. Most nuclear medicine services are delivered in metropolitan areas, meaning communities in rural and remote Australia already face challenges accessing these services. Cancer Australia data shows that those living in rural or remote areas of the country face an increased risk of dying within 5 years of their cancer compared to those living in urban areas. Consumer research by YouGov shows that people living in regional areas are indeed feeling the geographical divide when it comes to provision of cancer care. More than 1 in 4 Australians living in regional areas believe that the access to cancer care is not equal amongst everyone, but 9 in 10 Australians are in support of measures to ensure equal access to cancer care, regardless of location. For many nuclear medicine practices in rural areas, the cost of service delivery is exceeding the revenue, and this is due to both the ongoing lack of indexation, as well as increased costs of radiopharmaceuticals, utilities, and transportation. To date, 9 independent nuclear medicine practices in non-metropolitan areas have closed their doors permanently due to the unsustainable cost of service delivery. The issues relating to access are compounded by an increased likelihood that rural and remote patients will be required to pay out of pocket. For example, in New South Wales, there are currently 3 regional sites with functional scanners that continue to be unused as patients are unable to claim a rebate for the use of diagnostic imaging tests, and many are unable to afford the $800 to $1,000 out-of-pocket costs. In instances where a patient does not have the option of a suitable medical alternative within their hospital, they may be required to travel significant distances and endure significant financial and economic stress for crucial life-saving treatments. And thirdly, on reduced availability of nuclear medicine services. As costs continue to increase, the continued lack of indexation will create an untenable environment where nuclear medicine practitioners have no choice but to reduce the scope of their services as the revenue does not cover the total cost of service provision. The impact of service reduction results in the funneling of patients requiring nuclear medicine services into an already stretched public hospital system, and rural patients have to travel to metropolitan public hospitals to access these services. Some patients who live in areas which have closed nuclear medicine services end up receiving inferior diagnostic tests. These inferior services can provide unnecessary additional radiation exposure to patients with diagnoses that are often less precise and effective. This then leads to an inferior patient health outcome and additional costs being imposed on the healthcare system due to their inaccurate diagnosis or additional tests having to be done. For example, having invasive cardiac catheterization and non-invasive echocardiogram being used to make a diagnosis instead. In the cancer setting, the early detection of bowel cancer can result in the removal of the cancer for a cost less than $2,000. However, if not diagnosed and caught at a later stage, the cost of treatment rises to over $60,000 per patient on average. As roughly 78% of bowel cancer is diagnosed in late stages, the savings that could be gained from early and more accurate diagnosis and staging, including through the use of nuclear medicine scans, is significant. When these benefits are applied to cancer diagnoses across the entire population, the economic benefits of reindexation and thus increased usage of nuclear medicine-related items for diagnosis are clear. Despite all of this, the Australian nuclear medicine community remains competitive and is leading the world in the areas of clinical trials, innovation, sovereign supply, and theranostics, which is all at risk without indexation and the federal recognition of the importance of nuclear medicine in our healthcare system.